And I saw the gentleman here with the little dog walking in, and I thought, oh, he's out for a nice walk on a spring day, and then in he came. So I was like, that's so awesome. Spring. It's good to see you, by the way. It's been a while. Our kiddos are grown.
Testing 1, 2, 3.
Okay, so on this bright and sunny spring day, we're here to talk about end of life and death and dying. Who's excited about that? For me, I am very, well, as a hospice nurse, you have to be very open about things like this, and I like to think of it, Lion King, Disney's Lion King, the great circle of life. And it's not necessarily a taboo, like many of us, I think, have come to think of death. It's almost as if, as we're being born, we're moving towards the light. We're coming down that birth canal, and we're going towards the light. At the end of life, I've had the opportunity in a very short time to see and witness people reaching and going back towards the light. And so it's a really, really beautiful thing that I've become involved with. So I hope I can share some of my knowledge and excitement, and really what we can do to be proactive in our choices as we grow older. One of the things that I think the healthcare profession does not do very well is to talk about what people want as they're growing older, and as they are maybe given a diagnosis that's life-limiting illness. We're very good at treating people nowadays, but we're not so good at saying, hey, I think we've done what we can, and let's look at some alternatives. Back in the 1800s, communicable diseases were the things that really took people, and they took them really fast, and they died at home, and they died peacefully with family, surrounded by family. And as we approached the World War I, and after all of that, World War II, actually, things became more progressive in medicine, and it became more of a curative type of approach. And so it was gung-ho with technology, and we were going to cure things, and we're going to cure things and treat things almost to the nth degree. And I think that we've almost done a disservice to many patients because of the fact that we are doing so many invasive procedures, and we're not being honest with the patients, and even sometimes ourselves. Okay, it's time for a quality of life, not a quantity. I have a license plate that I got from Hospice Association when I started working, and it said hospice, it's about how you live, in capital letters. And I think that's really what describes hospice. How many of you have been told, or have had a loved one, a friend, some acquaintance, that they have told you, well, the doctor said there's nothing else we can do? Well, I mean, I think that's probably common to most of us, but there is something else we can do, and it's called hospice and palliative care. You can enter hospice when you've been given that 6-month window, although we have had hospice people, patients with us for, gosh, greater than 6 months. So you don't have to fit that cookie cutter mode of well, I have to die in 6 months. I know I do. So that's, there's no hard and fast rule. So that's the great thing about hospice. And we do take a lot of people also think, and I did as well, that hospice was just for cancer. And it's not. We can take, and we have taken people with cardiac issues, a lot of congestive heart failure. We take people with lung issues like COPD, chronic obstructive pulmonary diseases. We take renal, kidney diseases, Alzheimer's, dementia. So there is a vast array of disease processes that we do take in hospice. So, if you have questions about, if you know someone that is struggling and they've been given that, there's nothing else we can do. Well, yes, there is, and it goes way beyond the cancer diagnosis. Dame Cicely Saunders, Dame, for those of you that don't know, I didn't know this, means that she was knighted in England. I thought it was just, hey, Dame. But she was actually the founder of the first organized hospice in London, England, back in the 60s, excuse me. She founded St. Christopher's Hospice, and she was actually a nurse first, then became a medical social worker, and then went and became a physician because she felt so strongly about the hospice concept. And she had this wonderful saying that I would like to share with you now, and it makes so much sense. You matter because you are you. You matter to the last moment of your life, and we will do all we can not only to help you die peacefully, but to live until you die. And I think that sums up so much of what end-of-life care is truly about. Death and dying in America today, just to share some statistics, which everybody loves statistics, I know. Our healthcare professionals have a lack of knowledge in how to treat pain and suffering. There are so many times that we get referrals we've had referrals from not only here, but from Vanderbilt, from the hospitals in Louisville, and they'll say, well, this patient's taking 2 milligrams of morphine every hour. And we're thinking, okay, that's really not that much for someone who's filled with cancer. And they've got metastases, which means that it's spread in various places of their body. And we get them, and we end up putting them on a pain pump. And the last patient that we had that was on an extraordinary amount of morphine, which is our drug of choice, she was getting 57 milligrams of morphine an hour, which for those non-medical people, that's like something you would give a whale. You and I, if we have a surgical procedure and we're getting pain medicine, we're getting 1 to 2 milligrams of morphine every 1 to 2 hours. So imagine that amount of medicine for cancer pain. But so we think a little bit outside the box, and most of our healthcare providers struggle with that. And the other thing that we, I think as a society, struggle with is talking about DNR orders, which means do not resuscitate orders. You need to talk to your family members about what you want when you get ready to pass. Only about 50% of DNR orders they're written within the last 2 days before death. And we get, believe it or not, in hospice, we get people that come in without DNR orders. So if you've ever witnessed what we call a code blue, it can be very, very frightening, the things that happen to the body. So it's something that we continue to work on, to continue to talk to the medical professionals here in town about, and we're trying to reach out and educate. We need to start talking earlier, especially if you have a life-limiting illness, about what you want or don't want at the end of life. Most Americans prefer to die in their own home rather than institutions, but where do most of people that we know pass? In the hospital or nursing home. Hospice has been here in Western Kentucky since, I believe, the mid-70s. And so we've been able to reach out into homes, and have people pass in their homes, which is what they wish to do. But we've also had a new inpatient facility built, which is on Old Hartford Road. It's called Hartford House, and it is a 12-room, 13-bed. We have one room with 2 double beds for folks that, we've had couples that have both had terminal illness. And it is a very home-like atmosphere. I would invite you to stop by. It's just down the road from the Carmel home, across from Trinity United Methodist Church. But when their pain and suffering gets too bad that maybe their caregiver is not comfortable, they're just wore out taking care of them at home, then they can come into our inpatient facility and we can help get their pain under control. Most of the symptoms that people experience at the end of life are not only pain out of control, but also they have trouble breathing, especially if it's a cardiac or a lung problem. And believe it or not, we give morphine for shortness of breath, which really takes away a lot of that scary gasping for air type of phenomena that you see with these patients. A lot of things that you would think would be pain related, we don't treat as much of the pain as much as we do the what we call terminal restlessness, which is very common for those people who are moving towards actively dying. They just become extremely restless. And so they just, these little elderly people, they become stronger than you would just not believe, the things that they can do and how fast they can move. And so I had one little lady outrun me the other day, and bless her heart, she just had that terminal confusion and restlessness, and it was something that we can treat very effectively with Haldol. So there are definitely a lot of things that we can do when someone says there's nothing more that we can do. Yes, there is. When you hear the term hospice, does everybody kind of go, oh? You know, hospice has kind of this dark cloud over it, and I would like to change that. I would like to change the fact that talking about death is taboo. It's something that is a part of life, and if you have a belief in a higher power of your choice, and I like how, Randy, you were talking about how you struggled with things, and I like how this seems like a welcoming, you're not forced to believe in one particular type of entity, but it's something that we minister to all types of faith, and so I choose to call God as my higher power. But we treat patients based on their physical symptoms. we treat their psychological symptoms. Many parts of pain management is due to psychological and emotional pain. You know, there's a lot of unfinished business they might have at the end of life. Spiritual pain. We've had patients that have not come to terms with whatever their vision of a higher power, and we've actually had them tell us that they see demons in the room. And that was unsettling for me at first. And sometimes you think, oh, it's the medicine. And then you begin to think, okay, let's bring in our spiritual counselors. And again, not that we force any type of belief system on them, but we share with them what we can without forcing, and then allow them to share with us, you know, what kind of fears. Sometimes it was a situation growing up that it was a punitive type of faith that was imposed upon them, and they grew away from their God. So we work on many different levels with these people, and we have social workers that will help plug them into different things. You know, Medicare pays for most of our services. We have private insurance, Medicaid, of course, so, and we do not turn anyone away, you know, whether you have the ability to pay or not. So that's another thing, that there's so many good things about hospice that I'm obviously sold on. When someone begins to die, there are a lot of changes that we don't always think should be normal. For example, what have we always been taught? You feed a person, you give them plenty to drink, to be hydrated, you know, and that becomes just the opposite as they begin to pass. And a lot of that education to the family is hard for them to understand. We have a patient right now that, bless her heart, she's almost comatose, but that family wants to come in and feed this person. And just re-educating that as the body begins to go through that actively dying process, the thirst mechanism shuts down. The need for food is no longer there. In fact, to feed a person and to give them water is actually more uncomfortable for them than it is to just let them be. So there's a lot of education that we need to do with not only our healthcare professionals, but just the general public, in not being fearful of the hospice concept. And how am I doing on time, Susan? Doing okay? And we have started to reach out. We have a wonderful medical director. I don't know if any of you know Tamberly McCoy. She is our medical director, and she is a board certified hospice and palliative care physician. And I don't think she's had a day off since we opened in October, but she's amazing. And I think we have a really excellent service. We're the first inpatient unit in Western Kentucky. So that is something that Owensboro can be proud of. And we are not connected with the hospital whatsoever. We are a nonprofit agency, and really are funded by a big fundraiser that we just had last Saturday, which is the annual spring fling, and I think we had close to 1,000 people at the convention center, and that was our biggest fundraiser. But then of course we are covered by the insurance payments and that. How many of you fear, and you don't really have to raise hands or disclose this, but how many of you actually feared death? I can honestly say that I don't fear dying now. Number one, because of my faith. But I know that there is a place and an organization that I can go to that will take care of me. But many Americans have fear about dying because they fear they're going to die in pain. You know? I just heard a yes, definitely. You do not have to die in pain. We have so many tools in our toolkit that you do not have to ever, ever, ever die in pain. That is probably our number one thing when a patient comes in. We assess their pain and we titrate the medication until they're comfortable. And they're comfortable, but they're still awake and they're able to interact with their family. So we keep them comfortable, they're able to do what they want to do. We had a patient that wanted to go fishing, you know? And so that was their big wish. They wanted to go fishing, and so we got them comfortable with their pain medicine and something for anxiety, and they took off and went fishing, and about a week later, they passed, you know? So we have wish lists of things that, I guess, a bucket list, you know, if you will. And we try to make everything comfortable for the patient and fulfill what they want done until they become actively dying. We had a patient that had a huge birthday party at Hartford House and was awake and alert. And there were so many things that they got to say and do with their family. It was a huge gathering. I think our great room was full, and it's a pretty good sized great room. But they got to say and what they needed to and have closure, and about a week later they passed. So that is something that we can help control, definitely. Prolonged suffering and death. You know, there are physicians out there, including our oncologists, that will treat until they know that their work is done, and we get these patients too late before we can really control their symptoms. And I've worked with the oncologists here in town, but I know that, of course, a physician's goal is to cure, to heal, and they feel like it's an epic fail when that doesn't occur. So we get the patients and we get them too late. So the goal for hospice care and for us as providers is to get these early referrals. Now, does it mean I'm going out knocking on people's doors going, would you like to be a hospice patient? Well, no, that's not what I mean. I'm not out there fishing for things. And people that come in and disease processes. I don't, not an ambulance chaser or anything like that, but we can be most effective when we get early referrals. When a patient decides that they would rather have a quality versus a quantity, because any of you know that have had loved ones, especially with cancer, they have chemo and radiation, and it can be very, very hard on their body, extremely hard. And so it's really up to the patient to decide, okay, I've had enough of this. I want to live out my time and be at peace and go to Disney World or, whatever they want to do. And so that's a big fear that I think that we can help alleviate. Now, are you always going to be, pain-free and, happy and joyful and all of that? No, we've got ongoing, especially for family members of the patients. A year after the patient passes, we have grief and support services, counseling service for the patients and their families. So that is something that, we are not only there for the patient, but for the family. We turn it around from the medical model and we put the patient as the one that makes the decisions, instead of the physician. So there's so much more I could share, but what questions do you have? Yes, sir.
Yes, I've got a question on medical marijuana. I've had several people close to me who in the final days have had friends who were able to make them some cookies with marijuana, which helped it helped greatly in several instances. Is there any drive underway that you know of toward having medical marijuana available for especially cancer patients?
My personal opinion is I think there needs to be, and I think the tide is turning towards that. We're seeing some things happening out west that eventually will, I think, filter this way. We do have a form of marijuana, I guess for lack of a better word. It's a pill that we give. It's called Marinol. And it's very effective for nausea with our cancer patients. And so I've seen it a few times, but we have used it and it is definitely effective. But I've been meaning to kind of get on that and check that out because I think the trend is it's going to move this way. And it does help, you're right. Yes, sir.
Susan, I work in long-term care and I'm involved with the death and dying of people every 4 or 6 months. And a couple of things that I really like about hospice is, one, you don't have to have an acute diagnosis of cancer or heart disease. It may just be someone who's dying of old age and has a diagnosis of failure to thrive. Their body's starting to shut down, as you say.
Yep.
And the second thing is if you have a patient in long-term care at a nursing home, the hospice doctors are able to get the pain medication quicker than a doctor through the nursing home. It could take hours.
Yes, thank you for bringing that up because that is so true. We have sisters out at the Mount that are patients of ours. We have contracted facilities here in Owensboro and elsewhere that the hospice nurses will go in and take care of them in that facility. So we provide care in a lot of different venues, not just at home or Hartford House, but we also are in the long-term care facilities, and that's so true. We seem to have some connections.
So does insurance cover any of this?
Yes. For those that are over 65, when they come in, they elect the hospice Medicare benefit. So everything is covered, whether it be medical equipment, medication, our nursing services, physician services, everything is covered. Most of us will have, if you look at your private insurance, there'll be some type of a hospice benefit. We also do Medicaid for those that are not at that 65-year mark, but we do that. And then we don't really do private pay because it's pretty expensive, but that's what our fundraising events are for. We never turn anyone away because they don't have the ability to pay. So, yeah. I don't know who was first.
I want to talk about the living.
All right.
The people that are left, does hospice have any
We do. We provide grief counseling at no fee to the family members for 13 months after the patient has passed. We have a new grief counselor and spiritual counselor that is beginning to assemble some groups, because it's not just about the patient, the family member as well, of course. Definitely. So that's available at no charge, and that's just part of the hospice service.
I just want to say that my dad died of complications of Alzheimer's, and he was in the hospice at the VA in Murfreesboro. And, you know, having a nursing background, I know what good nursing care is, but these people, they took such dignified care of my dad. They would come in and shave him every day, comatose as he was, and they would talk to him, and they were so gentle with him and just treated him with such dignity and respect. And it put to life what I had studied in school. I was a gerontology minor, so I grasped at anything with that. And it really, I can't say enough about hospice care.
Thank you. I have too noticed that, and working in several venues over the years. What attracted me to hospice was the fact, number one, that I had more time with my patients and the family members, which is what I really wanted. I wanted to get to know them, their person, what they were about, you know, so thank you.
Before my mother passed away, she had a living will stating she did not want any kind of extensive life-prolonging care like ventilators or other things. Now, this was in another state. This was almost 9 years ago. And I'm not saying it was the right thing to do, but the doctors and the medical staff at the hospital did not abide by that. Really, they asked us if we wanted to do that. And I'm not saying it was the right thing to do. They should have just done it anyway. But I was the holdout, because in my head I was killing my mother if I said, okay, pull it.
Yeah.
So I'm wondering if hospice has anything, or if there's any kind of counseling for families that are going through that decision. I'm not saying it should have been left to us, but it was, unfortunately. And that's horrible. It's a horrible experience to know that you're the one that's going to pull that. And based on your religious upbringing or spiritual belief or something that you've been taught, you could feel like you are committing a mortal sin by doing that. So is there anything that's available to the family before the person actually passes to help them come to terms with those kinds of decisions?
Absolutely, and what you're describing is not new to me. There's, you know, pardon me, you feel like you're doing something wrong. Absolutely. This is my mother, my father, my son, my daughter, whomever. There's so many emotions. So we try, and we have a social worker, we have the spiritual counselors, and we work really hard, not only at taking care of the physical, but we get our social workers involved right off the bat. Because of the fact we get to know our patients so well, we have family members that we establish trust with them pretty quickly. And if there's a holdout, or if there's, you know, some family dynamics going on, we try and get in there and educate and talk about, you know, how are you feeling, what is going on. And so definitely we have a whole interdisciplinary team that we're right there, and we try and head these things off. Not head them off, I don't like that word, but we help you work through that situation. because a lot of times people don't have these discussions about a patient's end-of-life wishes until you get to a crisis stage. So we try and do that a little quicker.
Carson has a question. He's had his hand up for a while.
Well, I saw that. What are you doing up there, buddy?
Just hanging around.
All right, that's cool.
You had a question?
Yeah, this is about the, dying in pain or peacefully. I don't want to shock anyone, but is committing suicide an example of dying in pain?
You know, that's a really, really good question. That's an excellent question. It's a very thoughtful question. Yes and no. Where's your parents?
They're right there.
Okay, I think he's thinking. He's definitely thinking. Bright young man. You know, when people do that, I think they're definitely in some type of pain, whether it's probably not physical pain, but they definitely have some emotional pain going on. And that's a very sad situation. That's not something that we usually deal with at hospice, although we have had people. I had a patient just a couple days ago that lost his wife in December, and he is a hospice patient. And he told me the other day, he said, I just really would like to overdose and go to be with my wife. So those are very real feelings, and that's an excellent question. I don't know quite how to handle that. I might defer that to mom and dad for an after lunch talk, but I think it's very thoughtful. Good question.
Jake, you
I saw
had
your
I just
hand
wanted-
up too for a long time. And she's just kind of a little out of my peripheral vision, so.
Go ahead, Jake.
Go ahead, Jackie.
I just want to make a comment about the will business. What I did was try to preclude that situation. So I took my family out of the equation and picked the best friend who was to do what I wanted. And I wanted no particular interference of any kind. So I put another person in that situation. So at least you can fight off my family.
Yeah, and that's not unusual. It really isn't, and that's a good thing. There is, and I'll get your question, I promise, but while we're talking about family, if you go to the conversationproject.org, there is an excellent conversation starter kit about, talking to your loved ones about what you want or don't want, and finding the best time to do it. It's several pages long, but it's a really nice document that helps get the conversation started. And it doesn't have to be one conversation; it can be several. But it's an excellent tool to get that started early before you hit that crisis situation. So
What was that website?
it's theconversationproject.org. Yes, ma'am. I'm so sorry.
That's okay. You've given me time to come up with 3 points.
All right.
So everybody just forgive me. The first one that strikes me is that quotation you shared with us from the founder of Hospice in England. What she said, along with several people's comments about dignity, are exactly in line with our very first principle. So I think that's perfect. Hospice is perfectly aligned with our denomination.
I was thinking that, not to interrupt you, but I was thinking that as I was listening to the beginning of the service, I thought this is a perfect venue
Because
to
our
have
first
this.
principle is the inherent worth and dignity of every person,
Absolutely.
including during the dying process.
Yeah, I love that. It was a God thing for me, so.
The second point I wanted to make was I think that it's interesting that hospice sort of takes a different take or reverses, so to speak. The idea of the Hippocratic Oath kind of unplugged or revisited or whatever, first do no harm. Well, there's a whole heck of a lot of harm that's done in over-treating people.
Thank you.
And the third point that I wanted to make was just a couple of personal anecdotes. The first one is that goes to the idea of permission. When people are dying, my mother was a nursing assistant for 20 years, and so she helped people through that process, not as a hospice nurse, so to speak, but there were times when this particular instance will sound harsh for those of you who aren't familiar with what compassion fatigue is. But her nursing supervisor told her once when she was working at the VA in a long-term Alzheimer's facility, there was a man who was at the last stages of Alzheimer's, and he was hanging on and hanging on and hanging on, and her nursing supervisor said, and here comes the harsh part, Pauline, would you please go back there and tell that old man to die? And Mom went back there, and she said that she spoke in his ear very, quietly. It's okay. It's okay if you need to go, just go. Your children are fine. Everything's taken care of. And Mom said that old man was dead in a half an hour.
Mm-hmm.
Coincidence, possibly, but maybe not. And I was able to do the same for her in her dying stages. And I was with her. I held her hand literally as she was dying. Went through the permission process. We had many conversations, and she had made all the preparations beforehand. But I wanted to talk about what she started out talking about sort of in the beginning, that we fear dying. And we've gone from a time in the mid to late 19th century, early 20th century, where people were dying at home. People used to take photographs with the corpse.
Mm-hmm.
They used to dress up the corpse, take family photos. And now we've moved all that to the hospital. And my mother died in a nursing home, and I was with her. I got to hold her hand. It was horrible because it felt like I was standing and tied onto train tracks that I couldn't get off of because she was dying. But at the same time, it was a tremendous gift that I could see her through those last stages, to her last breath. And then I actually asked the staff, it didn't feel right to just leave her after her body. So I actually asked the staff, could I help dress her, bathe her, the whole 9 yards? And they looked at me like I was nuts. Either they thought I was nuts, or people just don't ask that. I'm not really sure, but I thought, I'm going to be done if I'm going to leave this, my mother, in the hands of people who don't know her. So I was able to help bathe her and dress her. I tucked her in bed. There was a Christmas tree in the room. I left that light on. And it was a full circle Lion King moment that was incredibly healing. And I wish that we would move more toward that.
And you're exactly right. When we have a patient pass, we encourage, especially if it's outside the home, we encourage them to spend as much time with that person as they want. We don't hurry them out. We don't say, get out of the way. We're going to clean them up. We're going to, and we've had people.
Well, initially that's what the nurses said, well, we do need to clean her up now. And I thought,
Yeah.
well, I'm not leaving.
Right.
And I said, well, can I help? And they said, well, okay.
Yeah. I think
I'm stepping out of this
it's
room.
foreign to those that are, used to, that's what we try and encourage.
It was extremely healing. I cannot explain the beauty of that experience. It was horrible at the same time, don't get me wrong.
Right.
But it was extremely, beautiful at the same time.
That's a good point. Thank you for sharing that. Yes, sir.
My mother died in 2003, and the hospice was a big help. But my question to you is the DNRs. I've got a
Yes.
brother in Florida that last year almost died twice. And the hospital informed me that the DNR had to be brought in with the patient, but they don't keep those on file. Can you elaborate on why that would be?
If they are a DNR, Yeah,
He's in the hospital 14 times a year at least.
it's always a good idea to give it to your personal physician. But a lot of times they will like to have that paperwork on file. They need to probably keep that on file. I don't really know what that was about, but when a patient comes in and they're not DNR, we go and ask them, and then it's on their chart, and it's a knowledge, thing, and, I'm not sure why that was the case, but.
Well, he lives in Palm Bay, Florida. For some reason or another, they've got multiple hospitals in the area. Most of the doctors, only about practice medicine in one particular hospital, so he ends up at a
Yeah.
hospital his doctor isn't able to practice in.
I
He has
think
to deal with the doctor on hand.
he probably got caught up in the medical quagmire
One
of,
time that I managed to have a patient of mine, you get the DNR and take it with us, the doc in the nursing room says, well, why in the hell am I even working on it?
Oh, dear.
well,
If you don't want me to
that's a
resuscitate.
whole nother discussion. But no, that's frustrating. I don't, yeah,
David.
yes.
I just was from what Pamela said about the excellent care. Hospice looked after my sister last year. She died in January 2013, and they were with her for about 4 months. She was in her 90s, had a fall, had microfractures in her back and intractable pain, and her physician could not prescribe her that named stronger medicine. It wasn't helping, so she said, get in touch with hospice. And they were wonderful. Immediately she was comfortable, and they were much better getting her to a bath than I was. I'm her younger sister. She knew how to say no to me, but she didn't say no to these gentle, coaxy.
Yeah,
And they were wonderful throughout.
I'm glad. That's good to hear. Yeah, definitely. Yes.
You mentioned spending time with patients, getting to know patients. I'm curious, is it ever difficult for the care workers saying bye over and over and over? And is it such a part of the significant part of the job? How does it feel for you?
It is, and luckily our grief counselors and our spiritual counselors are there for us as well. We grieve and cry with the family. For me personally, I know that they're out of pain and they've gone on to a better place. So that's how I choose to deal with it. But it's hard, and some days you go home and for me at least, I'm flat worn out. So, but it's just something that I feel called to do, so. Yes, sir.
My wife was with you most of the year, and she's the one that got you all in Western Kentucky at Veterans Center. And I recall a few days after she was there, they were needing some particular medicine, and you all made a special trip from Nations Pharmacy on 54 clear down to Hanson, Kentucky, just to bring that medicine.
Yep.
And number two, as his surviving spouse, I would feel comfortable now to go over if I had a question. I know you were very helpful in legality, notarizing papers, or maybe offer a little advice, what direction to go, and that kind of thing. And I'd also said a good word for I think you call them spiritual counselors, Caleb, I can't think of his name.
Caleb Potter, yeah.
But I would feel comfortable to go to him personally right now.
Yeah, that's excellent. I'm glad to hear all this, positive things. It's, we're fighting like a lot of other healthcare entities. The government wants to cut back on some of the funding and Medicare, and so I think this is such an important part of healthcare that is often overlooked. And if you take anything away from here, number one, consider hospice care early if you have a life-limiting illness or someone you love does. But also know that we try and cover all the issues involved, the family, the surviving family afterwards, the social issues, the psychological, everything. So I think hospice is an amazing concept.
And I'd like to mention the special, I don't know what you call it, but over at the Baptist out on 81, or 56, I guess, that meeting around Thanksgiving, you invited all the family, you know?
An evening of remembrance.
Yeah, okay.
Yeah, that was very moving.
Yeah.
Yes. Did you stand up and speak that night?
No.
No, okay.
Too many others, I didn't get.
You didn't get a chance to put your 2 cents in? Well, it's open. Yes.
Just real briefly, I wanted to follow up on Bill's point. I think the hospitals are doing a much better job about monitoring DNRs and healthcare surrogacies. People do. I would encourage people. Most people know what they want. It's a matter of communicating it and putting it on paper. And I know it's a difficult decision people make. As an attorney, I can say that it's a decision that can go hand in hand with drafting your will. It takes half an hour in an attorney's office, and it's very inexpensive and very quick and easy. And it brings such peace of mind to families to know that they're not going to have to be left with that decision. And it kind of goes to Dixie's point. I think it's important to make the decision, but it's as important to let your family know that that is your decision and that it was freely made. And so I would encourage people to talk to their families and to talk to an attorney and put it on paper. And the hospital will record it. I had a couple that had just gone through a wife losing her husband. And when she went out there, she showed the hospital hers and his, and they put them both on file. Certainly keep a copy, but in my experience, the hospitals are doing much better about honoring people's requests now than they have in the past.
That was one of the first questions when I worked at the hospital. You know, that was definitely something we tried to address, and that just sounds like a very unfortunate situation that.
Do you have volunteers, or do you have a volunteer program?
We do. We're always looking for more volunteers, and we have a training program that we put the volunteers through. Some volunteers like to do have patient interaction. Some of them prefer to just help in the office, arranging flowers, so if that's something that you're interested in, or anyone is interested in, I can definitely give you the name of the person to contact. Yep.
Carson, I think has another question. It's not a question. Hold a second. Hold a second. Mom?
Yes.
It's okay, tell them. How,
You don't need to.
Let's do that some other time.
Why don't you come on down, honey?
what?
Come on down.
Got that down.
Given the response and the number of questions we've had here, I think we may need to have you come back.
I would be delighted if
Come back without the speech and just take the question.
well, I thought about that too, because there was so much I got like notebooks this big, and I was like trying to figure out, so I did think about that for sure, because there's so many misconceptions, we don't kill people, we don't have a death panel, all those things that are floating around out there. Thank you so much for having me. I appreciate you bearing with me. I was a little nervous, as you can probably tell, but it's definitely needs to be talked about, so thank you very much.
Susan, thank you once again for coming out and sharing your insights with us. Beyond the call of duty to have to come out on Sunday morning, but we do appreciate it.
Great. And I've been wanting to come here anyway, so it was a good thing,
Thank you. If you'll locate your service bulletin, we'll say our closing words together. Take courage, friends. The way is often hard. The path is never clear, and the stakes are very high. Take courage, for deep down, here is another truth. You are not alone.